Good morning. This is Peter Petros from Sydney. I will be talking to you about interstitial cystitis being part of the posterior fornix syndrome and therefore potentially curable surgically. The hypothesis is that IC-BPS may be another posterior fornix syndrome phenotype caused by lax uterosacral ligaments failing to support visceral plexuses. I'll go into that later. The posterior fornix syndrome was first described in 1993 by myself and Ulf Umsten, and it consists of co-occurring chronic pelvic pain, urge frequency, nocturia, abnormal emptying, and raised post-void residual urine. And it can be cured or improved by uterosacral ligament repair. Now, to give you an example of co-occurrence, here's the posterior zone of the pelvis, and there were 198 patients in Gershon study with chronic pelvic pain. 68 had abnormal emptying, 127 frequency, 55 urgency, 63 nocturia. So this is 313 bladder symptoms. 198 patients with pain had 313 bladder symptoms. That conforms to the ICS definition of interstitial cystitis. Max Planck, the famous German physicist, said that insight must precede application. So the aim of this video is to provide some original insights into an entirely different anatomical way of thinking about IC-BPS. And it is my hope that the concepts presented here will be tested and challenged so as to further the understanding of this condition. So the title, Interstitial Cystitis, when part of the posterior fornix syndrome, is potentially curable surgically. I will discuss two cases, Scheffler's case report of cure validated by histology of IC Hunner's lesion, and then Gershon, 198 cases who set out to challenge Scheffler's findings. Scheffler managed a 73-year-old woman with second-degree symptomatic prolapse, cystitis, chronic pain, urge and frequency, and nocturia, but she was managed according to the standard posterior fornix syndrome protocol. Investigation, uterosacral ligament repair. When he did a cystoscopy, he found glomerulations and non-ulcerating Hunner's ulcer, and the biopsy showed large numbers of mast cells within the muscular layer. The surgery, he did cardinal and uterosacral ligament to cure the cystitis and the uterine prolapse, and a TFS mini-sling repair. At 3 years, the symptoms and prolapse were cured, and there was no evidence of interstitial cystitis on cystoscopy. The concluding hypothesis of Scheffler was that IC-BPS may be another posterior fornix syndrome phenotype caused by lax uterosacral ligaments failing to support visceral pelvic plexuses. Gershon tested the hypothesis of uterosacral ligament causation of IC-BPS for truth or falsity with 198 women with chronic pelvic pain and 313 bladder symptoms who had uterosacral ligament surgery for uterine apical prolapse. And there we are, 198 women had chronic pelvic pain and some apical prolapse. But they also had these symptoms: urge incontinence, fecal incontinence, bladder emptying, frequency, stress incontinence, nocturia, obstructive defecation, residual urine. And here are the numbers here. And here are the results of posterior sling on chronic pelvic pain, 198, 74% cure. Urinary frequency, 127, 79% cure. Nocturia, 63. 78% cure. Bladder emptying difficulties, 68 women, 52% cure. Urge incontinence, 55 women, 78% cure. And here we have stress incontinence, 66, 93% cure. Obstructive defecation, 80%. And residual urine, 44 women. Residual urine greater than 50 ml, 44 women with 54% cure. So we just don't go and operate on women because they have a combination of symptoms, although that is very suggestive. We have a pre-op testing for chronic pelvic pain and OAB in posterior fornix syndrome. And this same test can be applied for interstitial cystitis BPS women. And the speculum test here, put a speculum in, I'll go over that in a minute, relieves chronic pelvic pain and urge in 70 to 80% of women who have a posterior fornix diagnosis. So this is a 3D view of the pelvic brim, the bladder, the vagina, pubourethral ligaments up front, uterosacral ligaments behind, visceral plexus is on the uterosacral ligaments, the three directional forces, pubococcygeus, levator plate, longitudinal muscle of the anus, and the green arrows are the afferent and efferent impulses. And a speculum is just put into the vagina quite gently. So let's talk about the pathogenesis of pain. Weak uterosacral ligaments here cannot support the visceral pelvic plexuses, so they fire off de novo impulses. Along here they fire them off, which are perceived as pelvic pain. Urge pathogenesis. If the uterosacral ligaments are weak, then the pelvic muscles which contract against them also weaken, and they cannot stretch the vagina to support the urothelial stretch receptors from below. So the hydrostatic pressure pushes down on these stretch receptors, they fire off impulses to the cortex, and these are interpreted as urgency. Now, when you put the speculum in, the first thing it does is push the vagina backwards, and it supports the uterosacral ligaments. So it supports the visceral plexuses, and the force of gravity doesn't pull on them to fire off impulses. But it also supports the urothelial stretch receptors and prevents them firing off impulses to be interpreted as urgent. So the definitive test is the Bornstein local anesthetic test. How do you prove that these visceral plexuses actually fire off impulses to cause pain? The Bornstein test, you inject local anesthetic at 4 and 8 o'clock into the uterosacral ligaments near their insertion into the cervix, and it has been found that chronic pelvic pain in women with interstitial cystitis can be relieved for 20 minutes. And that's multiple sites of chronic pelvic pain. That's near the urethra, the lower abdomen, and contact pain with the cervix. But it also provoked vulvodynia for 20 minutes. So the chronic pelvic pain of vulvodynia can also be relieved by the Bornstein test. So here we have a view of the pelvic organs. There's the sympathetic plexus coming down here, the parasympathetic plexus. They join together to form the visceral pelvic plexus. And here in yellow, we have the afferent nerves from the end organs, bladder, pelvic muscles, vagina, vulva, rectum, and also, not shown here, from the coccyx and lower abdomen. And these are supported by the uterosacral ligaments, and if the ligaments are loose, the force of gravity pulls on them and they can send off impulses which are interpreted as chronic pain. Now, it's important to understand that these bundles, these are in the visceral plexus form bundles. And it's when the bundles are not supported, then it explains how you get multiple sites of chronic pelvic pain, and how the multiple sites are relieved when you put the speculum in, and the multiple sites are relieved when you inject the visceral plexus with local anesthetic. A hypothesis for Hunner's ulcer causation. Weak uterosacals cannot support the VPs, which send afferent impulses to the cortex. The cortex reacts to impulses from the visceral plexus by sending efferent impulses to the end organ to stimulate hypothesized sleeper cells, which activate an inflammatory response. So the sleeper cells create mast and other inflammatory cells, and even a proliferative neural response, which is seen in both interstitial cystitis and vulvodynia. Now, because the urothelium is thin, the inflammatory response can create an ulcer. There is also an inflammatory response in vulvodynia, but because the vaginal tissues are very thick, no ulcer is created. Finally, how do we clinically test if IC-BPS is a phenotype of the posterior fornix syndrome? Well, we can use the diagnostic diagram here and check for these symptoms: emptying, frequency, urgency, nocturia, and sometimes these bowel symptoms, and of course chronic pelvic pain. But the second simple test is the speculum test, which we've described. You put the speculum test in, and in 70 to 80% of the time, it will cure or improve temporarily the urge and the pain. Thank you very much.